everyone, it's Sarah from BJC here, coming to you from a nice sunny day in Sydney, wanting to introduce our next lifestyle event. So if you've seen some of the content that we've shared before, you'll know that we love hosting live online events where we provide education and hopefully really useful information to help people manage their rheumatic condition and help them live and feel that little bit better. So this upcoming seminar is all about knee osteoarthritis, which is incredibly common. And we're going to focus a little bit on how physiotherapy can help. So there's lots of different things that have been shown to help knee osteoarthritis, but the seminar today is really focusing in on physiotherapy and what you can expect to receive, or what physiotherapy treatment is all about when it comes to knee osteoarthritis. The upcoming video is part 1. If you'd like to watch part 2, then please log into BJC Connect. You can set up an account for free and you can see part 2 of the presentation. But for now, I'll hand you over to my colleagues and enjoy watching.
Welcome everyone. Happy Wednesday evening. It's nice to see so many people joining on yet another Wednesday evening. We've also got, we've got a few guests today. For those of you who don't know myself though, my name is Errol Lim. I'm a physiotherapist by background, but I'm also the Managing Director of BJC Health. And we're going to talk about knee and knee osteoarthritis today. And I'm very gladly joined by 2 physiotherapists whom I've worked with for a very, very long time, and they'll help to answer your questions and comment on any of your comments throughout the night. And they are Belinda Prince and Tim Lee. Maybe you guys can unmute and just say hello so that your face will come up.
Hi, Belinda.
Hi, Belle.
Hi everyone. Hi, Maggie.
Hi.
Hello, it's Sandra.
And again, as always, for those of you who've been on before, please make comments. Please ask your questions. We hope to answer them through the night. I've got a few slides prepared, and if there's a need to break, I will break, and we'll go to questions. Otherwise, I go right through. It should take a good 10-15 minutes or so, and then we'll really break for questions and discuss any questions you have around knees. Yep. So I'm about to share my screen, and we'll go straight into the presentation. And whilst I just get everything set up and check my screen here so that I've got everything in place, which is great, so that I can see all of you. And I hope if someone can give me a thumbs up that you can see the actual slides, that would be great. Oh, thanks, Val. And I'm just going to call up the chat as well. Brilliant. So we're talking about osteoarthritis of the knee, and specifically more around how a physio can help. Knee pain and definitely knee osteoarthritis is something that's very, very common in the Australian community. And how common is it? Well, you can see there with the statistics and the figures, it is fairly common, right? Especially if you're over the age of 65 or over the age of 80. Many people suffer with knee osteoarthritis or have knee osteoarthritis. And if you include everyone in Australia, it comes to about 1 in 7 people at any one time might present with osteoarthritis. When it comes to knees, it's definitely more common in females. And that's really because of the biomechanics in terms of the wider hips and the angles of the legs going down into the knees that may cause some extra stress at the knee joint. And when you survey and when you ask many people with knee osteoarthritis, or knee OA as we shorten it, about 50% of people say it's hard to perform everyday tasks when they have this particular condition. So what is osteoarthritis? So if we go with, and we break up that particular word, so osteo means bone, arthro refers to the actual joint itself. And the itis, like itis in many other conditions, is inflammation of. Now, that's a ridiculously broad term because especially us working in a rheumatology center, and all of you who may attend a rheumatology center like ours, that like relates to 100 different diseases or 100 different conditions. And what's happened is that over the years, when they first utilized this particular word osteoarthritis to refer to this particular joint inflammation, other different diseases got all sorts of other names. And basically, we ended up with this term osteoarthritis for people with this particular condition, where it refers to the wearing away of particular parts of an actual joint, which typically refers to the cartilage. And cartilage is sort of that shiny surface that protects the bone. So for all of you who eat chicken, if you look at a chicken bone, it's that shiny bit at the top of the bone, right? And so that's cartilage that protects the actual bone. The meniscus, which is sometimes referred to as cartilage, the meniscus are these shock absorbers that exist in joints. And in knees, they're two big discs that you see, and I'll show it to you on an x-ray where they exist in a minute. Labrum, they're different parts and different cartilaginous structures that help to keep a joint mobile and working well. And again, you can get some bony changes with osteoarthritis. So that's what osteoarthritis refers to. And very simply, for those of you, those of you who might have your video on, how many of you have had a knee x-ray? Anyone? Put up their hands. Well, about 4 or 5 of you. So about, 40%, maybe even 50% of the people with their videos on. And so when we're looking at a knee x-ray, and I've titled this No OA versus someone who has osteoarthritis, and hopefully you can see that. You can see my, I'm going to move my cursor here. This is like a pretty good knee joint just here. And the reason why I say it's a good knee joint, you'll see nice clear space in between the two bones. So this is the top of the bone, right? Your femur, and this is your tibia. Yeah. And so again, nice good joint space there, and the edges of the bone look all nice and smooth. If we go on to the picture in D, you might see a picture like this, and you can tell automatically that X-ray in D doesn't look as good as the X-ray in A. Yeah, do I see some nods? And that's because, the meniscus, or those discs in the knee, have worn away a little bit on this side of the joint, and that's why you can start to see there's less of this beautiful black space there. Yep. And you can see that at the margins of the bone, there's a little bit of what we call irregularities and things, the bone's getting a little bit sharper, and the body's sort of created a little bit more bone to protect the actual joint. And so we can say that this is a progression of osteoarthritis in someone's knee joint. And a picture like D in the past, like some, early in my career, I would show someone something like this and say, well, that's why you've got pain and so forth. That's because your knee has, to some extent, if I use a terrible word, deteriorated or worn to get to this particular point in time. However, a very important point to share with all of you is to not really focus on these x-rays. Yep. Now that's really, really hard, isn't it? And for those of you who've seen doctors, specialists, physios, all sorts of other allied health practitioners in the past or for many, many years, very often we sometimes focus a lot on the results of an investigation and what might be wrong. But what we now know with especially something like knee osteoarthritis is very often the picture actually doesn't really tell the story. Yep, you really need to match up what you find on investigations with how the patient actually feels. Yeah. And so, and why I just labeled this slide important slide, because this is like the take home message. And let's read it together. The first box on the left. Many people with an osteoarthritic knee have minimal or no pain. Minimal or no pain. Yep. And on the flip side, actually, many people with no pathology and no osteoarthritis on x-rays can have severe pain in their knee. Right? And the question is, what's going on? And I think the important thing to realize, first of all, is that people can have pain in many parts of the body, but especially in the knee, for all sorts of different reasons. And that's really the job of the practitioners you see working with yourself to figure that out, right? So don't always focus on the x-ray results. Now, with those of you who have suffered with knee pain for a long time, so people who've had, say, joint pain in the knee, or been diagnosed with osteoarthritis for a while, it's important that you understand your pain and when the pain that you feel is something that you should be worried about, and whether, if you've got some residual pain, and you get a bit of an increase in pain, should you really be very worried? Or actually, you know what? It's a little bit part and parcel. I can at least still walk, go up and downstairs. I can still go for a hike if I want to, climb up a particular hill. If I can do those sorts of things, but I have a little bit of pain, you know what? Actually, that should be okay. And again, you should be working with your practitioners to understand whether your pain levels are something that you can deal with, or whether it's something where you need a particular intervention. So that's the important take home when it comes to osteoarthritis of the knee. Now, if we come and we look at management, right? So unfortunately, people have had knee pain for a while. You might have gone for the x-ray, you've seen some professionals, and it's been knee pain that's been increasing over the last 10 to 20 years. And it's starting to stop me walking up steps, down steps. I can't squat fully, and I can only walk, say, for 10 or 15 minutes, and then things are starting to hurt, and hurt quite a lot where I need to stop. What do we know, and what does the evidence show? So we created this particular checklist some years ago, looking at all the research, and one of our rheumatologists who has a special interest in osteoarthritis helped us create this. And we use, this traffic light type scenario to help explain what works best for people. And so you can see there right at the top, for many people, at least in Australia, the best thing they can do when they suffer from pain due to osteoarthritis in their knees is to lose weight. Yeah. If you can lose a tiny bit of weight, it can really take off a lot of pressure off the joint. And apart from reducing your pain, it can increase your function significantly. Now, I've said that all in a couple of sentences. Weight loss doesn't come that easy, as many of you will know, right? It requires a lot of effort. And even though you've come to a physiotherapy talk on knee osteoarthritis, I've just shown you the slide that shows you that weight loss is actually the number one piece of evidence that we have to help with pain. So from a physiotherapy perspective, if we just did what we did and didn't tell you about the importance of weight loss, we'd really only be doing half our job. Also, remember, the weight loss helps us as physiotherapists do what we do best, which is to help you with exercise, to help you with all the other modalities which I'm be talking about below. You can also see there with the green light is exercise. Yeah. And those of you who've also joined us on these fortnightly Wednesday workshops have realized the importance of exercise for so many different conditions. It is no different with knee OA, right? And it comes to definitely to strength and flexibility and mobility. Getting people just to increase their activity automatically helps make people feel better. Now, things in the 3, 4, 5, 6, and 7 have good evidence, but they're not as strong as what's above them. But if you do these things in combination, right, there's no need to do these things one off at a time. But if you do these in combination and work with your clinicians or practitioners, they can really help. Yeah, to reduce pain initially, to then maybe perhaps tackle weight loss and help tackle exercise. You'll see there are a few other things. I go on to number 8, which is PRP, which is platelets being re-injected back into the knee joint. So what doctors may do is actually take out some blood from you. They spin the blood up, and then they take some of the platelets out and they re-inject it back into your knee. Again, that needs to be much more investigation in terms of the research around that. But for the right person and perhaps someone with severe osteoarthritis, that can help a little bit with pain and function. For things like 9, 10, 11, and 12, over the decades of research, these things have really shown now to not help knee osteoarthritis at all. Yeah, and I'm happy for those of you who have trialed 9, 10, 11, and 12 to make comments in the chat box so that others can know and perhaps share your experiences. But really, the evidence shows that these are strongly not advocated, yeah, when it comes to osteoarthritis of the knee. So that's something we'll refer to. I've got some more slides on this, but let's really look at 1 and 2. Now, why have I written 1 and 2 like this? So in terms how I presented the evidence, see how it looks like it's beautiful, like 1's there and 2, it's all quite succinct. It's really like this. That's how I should have presented it. The evidence for weight loss is so strong when it comes to reducing pain, especially when it comes to knee OA, right? And second, and exercise, though ridiculously important, is a little bit quite far down on that chart. Now, it's a little bit different when you do it in combination, but there's a little bit more to that slide. The problem we've had, I think, with weight loss is often it's very hard to speak about this subject, yeah, to many patients, yeah, because it's not like many of the patients know that it's a factor. It's about maybe taking charge or working with your practitioners as to how to best tackle this, yeah. And more often than not, it's not. I guess it's part of the physio's job to discuss this with you. But of course, many of you here who've already been on these sessions know Monica Kubizniak, our resident dietitian, who works with many of our patients on this. Right? Now, the next slide probably sums it up better, because there's very strong evidence that show if you do the combination of weight loss and exercise together, that's better than weight loss alone. And that's better than exercise alone. If you can do the combination, that obviously gives you the best results. But hopefully that makes sense. But it's not that easy. I've already said that. And so typically people need a lot of support. And that's why I guess at BJC we've created the team that we have and provide the services that we do, because it's not easy work. It takes effort. It takes setting of small goals so that you can achieve those and gain confidence to then go that next step. Those of you who've also heard me speak or heard others speak here, we basically think exercise is the first avenue to tackle. If we can tackle exercise first, we tend to be able to hopefully help patients on the journey and get them more confidence so that they can tackle harder things like reducing their weight, sleeping better, improving their mental well-being, and so forth. Then you can see number 3 and number 4 comes after that. Now, when it comes to physiotherapy, I guess specifically, and of course our exercise physiology team at BJC, we work very closely together. Both physios and our EP team work so closely to help our patients. When someone presents with pain and they present with chronic pain in their knee, we need to help them reduce their pain. Of course, it's great to have a doctor's involvement in there, but sometimes we need a little bit more. So all those things in number 3, number 4, number 5, number 6, number 7 can all give short-term pain relief. And what that allows us to do, if we can get short-term pain relief, is to allow someone to be a little bit more active. Yeah, to take charge a little bit more, for us to be able to prescribe some exercises that can actually start to help someone. Weight loss as well, of course, reduces pain, as we've already said, and that then allows someone to increase their activity to then help improve their function. But weight loss tends to be a much longer term strategy. Whereas those in the boxes of number 3, 4, 5, 6, and 7, those can give you much quicker gains. Straight away from a physiotherapy perspective, and perhaps in the first couple of sessions that you might see a physio, is that braces, walking aids, all sorts of different aids can help instantly. Yep. And so, yeah, put that then. They're easy wins, because if you can reduce pain, you can change how someone moves. And if you can change how someone moves and reduce pain, they're more likely to then exercise. Now, this principle doesn't just work for knee pain. It's just that there's good evidence for knee pain, but it works for hips, lower backs, necks. The quicker we can reduce someone's pain, the quicker we can change someone's aberrant movement patterns and get them moving more normally again, right? And that helps someone exercise. This is just a picture. I've just got a few more slides. This is just a picture about bracing options, different types of braces that might help with someone's knee pain. They look quite involved. I know some of you looking go, I will never wear something like that. There are easier forms that might help too, but these are some of the other ones on the market if someone needs a little bit more stability and support. Now, in comparison or contrast, these are just some basic taping techniques that we can do for someone with knee osteoarthritis. Very easy, can be done in a couple of minutes, but of course give someone some relief. We already discussed to some extent exercise and physios, and our EPs of course focus a lot on exercise, but doing exercises correctly is important. Why we utilize the camera is to explain and educate to patients why alignment or joint alignment is so important, because just changing the position of your knees or your hips can make a huge difference to pain levels, and definitely make a huge difference to the effectiveness of the exercise that you do. Now, from a specific physiotherapy perspective and the rehabilitation perspective for someone who presents with knee OA, can we please make the assumption that someone either doesn't require the strategy of weight loss, or is in combination already working on weight loss strategies and then working with our physiotherapy team in tandem? We've come up with a protocol for someone with knee OA. Again, it is not rocket science. We didn't invent this. This is with all the research out there. We've then collected and just put it in 9 basic steps. And it needs to be followed in order. The problem with humans, and I cheat, I try to cheat anyway, just like everyone else, is we typically like to stage jump. We don't like to try to follow the stages. And often when you stage jump, you don't come from a solid base. And so typically there's a greater risk of failure. And so where people tend to stage jump is they want effective pain relief quickly. And then they'll go, you know what, I can sort it out myself. It'll be fine. I'll be okay. I'll watch some exercises on YouTube or whatever it might be, and I'll try to do it myself. And the issue is the rehabilitation process is quite clear cut, right? Let's take for granted that 1, 2, and 3 are done with whichever clinician that you see, be it your GP, your specialist, or your allied health team. You've been lucky enough to get some pain relief. Then the hard bit comes here. That's why it takes time making sure you exercise correctly. And these are basic rehabilitation principles that actually all your clinicians studied. But unfortunately, they studied it in their first year of their undergraduate degree. And maybe if no one actually got them to repeat it or they didn't discuss it, maybe that's why they might not take patients through all the time. And sometimes I think we need to be better educators in educating our patients or the people that we see that really it's a longish term process. Doing things correctly right from the start. Let's make sure you're more mobile. Let's get the right muscles firing at the same time. And only once those muscle firing patterns are going well, can we concentrate on your stability. And before we and only when that's good, you know what? Let's carry the big weights at that point in time. Yeah. That's really the step. Or sometimes, unfortunately, people stop at number 6 and they don't carry the big weights, but then they still want to walk for long periods or go on a big trip, because eventually you need to carry the weights, because if you don't do the resistance training, you never build the muscle. Those of you who already know our EP team or our group of exercise physiologists know that, well, you know, that's why they push you, right? They push you to lift the weights because it needs to be hard or else you don't build the muscle. Then after you've done all that, then perhaps you can do some things on your own.
So there you have it. That was part 1 of our knee osteoarthritis and physiotherapy workshop. If you'd like to watch part 2, then please create an account for BJC Connect. It's free and you can access part 2 of this recording at any time, as well as other recordings and other resources that the BJC team have developed. So thanks so much for watching. If you like what we're doing, then please give us a like or subscribe to our channel. We look forward to seeing you soon.